Sir, yes, sir. Now you can slide show. Yes,
Now
sir.
we can see you. Yes.
Yeah. Okay. So
Okay, sir.
the topic of the day is, for me, it is stable COPD management. Basically, how we manage COPD in OPD settings. So in the next 25 to 30 minutes, I'm going to discuss briefly in nutshell about the principles of COPD management with a case background, case scenario background. And I'm going to stick the treatment plan of COPD patients based on the currently available gold guidelines and other international guidelines. So we all know that why COPD is important, as Dr. Harish clearly told that COPD is an emerging fourth to third leading cause of death worldwide, and almost 6 million deaths annually, according to the gold reports. Annual deaths are happening because of COPD, and from 2001 or from the early 2000s to the newer guidelines, if you see that, then previously it has been mentioned that COPD is a irreversible disease. Now the latest guidelines say it's a preventable and treatable disease. So the definition itself is changing, and there are a lot of positive scopes and positive thinking about the COPD treatment, and newer advances are happening. So we should know about all those things. We should be updated all these things. And early diagnosis and a comprehensive approach, including pharmacological, non-pharmacological, along with pulmonary rehabilitation and other modalities. The disease is, the comprehensive approach has made the better quality of life among the people, and significant proportion of our outpatient clinic comprises of COPD patients. That is very important. This is about the COPD in nutshell background. If you come to the COPD background, COPD burden in India, yes, definitely it is second highest killer after the heart disease among the non-communicable diseases. You can see the graph clearly showing that COPD numbers in 2017, sorry, 2016 in different states all over the India, being Jammu and Kashmir being the highest numbers. And this data shows that highest numbers in Jammu and Kashmir is because of the biomass fuel exposure is very high in that state, and in other northern states as well as southern states also. So COPD has created almost 9,58,000 deaths in 2017 in India alone. And very importantly, non-smoking COPD is highest in this part of the globe. So India is considered to be contributing to the highest COPD, non-smoking COPD patients in the globe. Basically, it is because of biomass fuel and increasing prevalence of air pollution and indoor pollutants like mosquito coils and agarbattis, dhoops, and etc., etc., etc. So basically, India has got a very big number of COPD patients, and the burden is growing over the years, and it is not as previously thought. In the COPD is patients are very small in number, so we should be concentrating, and we should be giving considerations to these type of data. So to start with, and to improve the understanding, we'll start with the case scenario. This is a 60-year-old male smoker with a 30 pack years of smoking, who has been diagnosed to have COPD 2 years back from his local clinician physician, and he has been prescribed on inhaled medications. He has been taking this salbutamol and dexamethasone combination inhaler for the past 2 years, and he has been hospitalized once in the last year at his from his local physician because of an exacerbation, and he was treated appropriately. And he had another exacerbation without hospitalization. And for the past 6 months, he is relatively stable, but he has significant grade 3 dyspnea, and his main complaint is becoming thin, and appetite is losing. His appetite is losing, and his dyspnea is progressively increasing. So clinically, this patient is a poorly built guy with a barrel-shaped, typical barrel chest. He has got mild pedal edema both sides, and saturations in room air is 92%. He's got a loud P2 on auscultation, and air entry on both sides decreased. So classically, it is a finding for an emphysema on the chest examination classically. and the chest X-ray confirmed that he has got an emphysematous lung, and spirometry, the basic value of FeV1 was 43% predicted. This is post bronchodilator, and the FeV1 FVC ratio was 0.65. The 6-minute walk test just 210 meters, he desaturated to 84% on 6-minute duration at the end of 6 minutes. So basically, with this background, so we understand that this patient is probably a severe type of COPD who has been not optimized with medications and has been progressively increasing symptoms in the past 2 years. And this patient particularly needs optimization of the treatment as well as the other modalities to be implemented to optimize the treatment. So first and foremost thing, when we diagnose a COPD patient, the next step is to stratify the risk and stratify the group of this, stratify the disease severity. So based on the gold guidelines, this is the formula. So initially, if the patient has got a FeV1 FVC ratio of 0.7, less than 0.7, then based on the FeV1, the degree of obstruction is determined. And based on the number of exacerbations in the past 12 months, he can be categorized accordingly to individual groups, and based on his individual symptomatology, based on the MMRC or CAT scoring. We all know that, so I'm not too much emphasizing in it. So in our particular patient, so post bronchodilator FeV1 by FVC is less than 0.7, and this patient's FeV1 is 43 post bronchodilator. Those basically this is gold grade 3 dyspnea, gold grade 3 obstruction, and he has got one hospital admission in the last 1 year, so it's coming as severe category, and his symptomatology is grade 3 MMRC, so it is falling probably in group D of the COPD with a grade 3 grade 3 obstruction according to the gold guidelines. So this patient is basically group D, gold 3 category. So what is the difference between a stable disease and acute exacerbation? Basically, there are two phenotypic or two presentations of COPD can be there. Either the patient can present with a stable disease or it can be an acute exacerbation will come to you. So stable disease is relatively stable without much worsening or acute worsening of symptoms in the past maybe 2 to 3 months. And there is no exacerbations in the recent past, for example, at least 12 weeks. And radiologically, we don't give that much importance, but radiologically, the patient may be stable and able to manage his daily activities with medications. So probably this could tell us that this patient is, we are dealing with a stable disease. And in case of acute exacerbation, as per the definition, it is the acute worsening from the normal day-to-day variations requiring a change in the treatment. So that is defined as acute exacerbation. And a fall in FeV1 can last for 12 weeks before coming to baseline. So this also needs to be considered. So until completed, we cannot say it is a stable disease, and there may be a radiological worsening in terms of presence of pneumonia or some other abnormality, which can be a trigger for the acute exacerbation. So radiologically may be normal also. Is not mandatory. So basically, we understand that our patient probably falls under a relatively stable disease of COPD. So basically, the goals of treatment for a stable disease is number one is the symptom relief. So patient symptom relief is the first and foremost thing to be achieved in a COPD patient, and we should offer a reasonable activities of daily living. So he should be independent for his day-to-day activities. That is the another goal, and to achieve an acceptable functional capacity. So patients should be mobile and patients should exercise capacity should be improved from the baseline, and to slow down the further progression, we should aim for that, and to reduce the risk factors. So already we found that this patient is having a smoking as a risk factor, or if there is any other risk factor found for a particular patient, then probably related to occupation or biomass fuel exposure and so on. So the risk factor reduction is important, and prevention of exacerbation. So further exacerbation prevention is another aspect, another facet of the treatment. And early identification and timely treatment of, if at all, if it happens, exacerbations, then probably early identification and timely treatment to prevent hospital admissions and so on. So every hospital admission makes very significant impact on the patient's health as well as the cost related aspects. So if at all, if there is a mild excess effusion, patient should be treated accordingly and appropriately to prevent hospital admission. So these are the basic goals of treatment for any stable COPD. So if you understand that pathophysiology of COPD in a better way, that you can see here that from the normal airways it becomes the airway constriction because of the significant airway inflammation, because of the noxious particles here. So there is a mucus hypersecretions and exudative secretions there, and because of the disruption of the alveolar attachments, because of the emphysema, so the alveolar attachments are disrupted, and mucosal inflammation causing repeated chronic inflammation leading to chronic fibrosis and airway neuralgia. This is the basic pathogenesis. We all know that. And because of the significant expiratory airflow obstruction, and because of the loss of airway, alveolar attachments, so there is significant airflow obstruction during expiration, which can lead to air trapping more so on the exertion, becomes a dynamic inflammation, which is the most important and sole pathophysiological factor for dyspnea in a COPD patient. So basically, we have an airway obstruction leading to dyspnea, and air trapping and dynamic hyperinflation leading to dyspnea. So these are the two important pathophysiological changes which happens in COPD patients, and these pathophysiological changes has to be addressed pharmacologically to achieve a symptom relief. That's what bronchodilators are doing. So basically, bronchodilators are the basic important component of the treatment of COPD patients. And because there is a mucus hypersecretion and intense inflammation in the airway, the airway gets narrow, and the cholinergic default tone is increased. So basically, there are two mechanisms: either the beta receptors are activated and there is a smooth muscle constriction happening, which can lead to airway constriction apart from airway edema, and there is a loss of cholinergic tone, which can lead to muscarinic receptor activation is another reason for the airway constriction. So we should target about the both beta 2 receptors as well as the target the cholinergic tone. So we have to target the muscarinic receptors as well as the beta 2 receptors. So beta 2 receptors, we know that short-acting beta agonists and long-acting beta agonists, and muscarinic agonists again divided into short-acting and long-acting. So coming to the bronchodilators, basically we have short-acting beta agonists like salbutamol, levosalbutamol we have, and short-acting muscarinic agents like ipratropium we have, and long-acting beta agonists like indacaterol, vilanterol, and salmeterol we have, and long-acting muscarinic agents like glycopyrronium, tiotropium we have. So what basically bronchodilators do? So inhaled bronchodilators or COPD are these central part of the treatment. They are the very important treatment aspect. And regular and as needed use of SABA or SAMA improves the efficiency. Basically, very early COPD patients, we need to treat them with either on-demand SABA or SAMA is enough. Most of the times, we do not see these type of patients. Basically, either patient will not come to you at this point, or COPD is misdiagnosed as some other disease, and patient can get some other disease. So basically, very early COPDs usually do not see in this. So these type of category, these SABA alone or SAMA alone treatment is usually we don't encourage, or we don't see these type of patients in our OPD. So combination of SABA and SAMA, yes, definitely better than the individual drugs. And most of our patients are coming in either group B or group C or group D patients. So basically, we start with either LABA and LAMA, either individual or in combination. So always the evidence says that combination is better than the individual agents, as in terms of bronchodilator effect as well as the prevention of exacerbation effect. So basically, LAMA have greater effect in exacerbation reduction compared with LABAs, and combination treatment of LABA and LAMA increases the FEV1 as when compared to the individual drugs alone. So basically, the cornerstone of treatment is bronchodilators, and other group of drugs which can target the inflammation, intense inflammation in COPD, are the anti-inflammatory part. So anti-inflammatories are the inhaled corticosteroids, oral corticosteroids, PDE4 inhibitors, and some of the antibiotics, and some of the other salvage type of treatment like mucoregulators and anti-inflammatory agents, which have got no much of evidence. So the proven therapy for anti-inflammation is the most important inhaled corticosteroids, And specifically during exacerbations, probably oral corticosteroids will give a symptomatic, reduction in the inflammation and reduce the hospital stay, and other anti-inflammatories and antibiotics and so on. So basically, we have two components of treatment. Either first is the symptom relief and the risk reduction. So the symptom relief, short-acting bronchodilator, long-acting bronchodilator, either alone or in combination, can help to relieve the symptoms in terms of beta-2 agonism as well as the anti-muscarinic agent antagonism. And in terms of risk reduction, that is the reduction of risk reduction for the exacerbations. An inhaled corticosteroids may help either in combination or alone. Either in combination with beta-2 agonist alone or in combination with triple drug therapy. So coming to our patient, as we have determined that the patient group falls in group D, so either preferably a LAMA alone or LAMA plus LABA or an ICS could be the optimum treatment choice for this patient. So to optimize this patient, tiotropium or glycopyrronium can be alone added, or LAMA-LABA can be added for a patient. A corticosteroid should be given specifically in patients who have got eosinophils more than 300, or if there is no bacterial colonization in the airway, or the patient has got repeated exacerbation, then probably inhaled corticosteroids should be added, and we should be very cautious in adding inhaled corticosteroids. And this is the gold guideline, says that history of hospitalizations for exacerbation in COPD and more than 2 exacerbations in the last 1 year, the blood eosinophil counts are more than 300, and if there is a concomitant asthma that is overlap syndrome, COPD asthma overlap syndrome, then probably inhaled corticosteroids may help, and they may be considered in patients group of who are showing eosinophil count of 100 to 300 also, but should be very cautiously used in patients who have got a recent pneumonia and eosinophil count less than 100, and patient who has got tuberculosis. Then we should be very cautious in treating these patients with inhaled corticosteroids because of risk of repeated pneumonias and other complications. So our treatment does not end here with the pharmacological treatment alone. So once the pharmacological treatment is optimized, then probably we need to review the patient frequently for his symptom assessment and other aspects of the treatment, like smoking cessation and vaccination, lifestyle modification, and self-education, including the inhaler techniques and compliance with the medications. And whenever the patient comes to a review, then probably you need to check all these things. The patient is compliant or not, whether he is taking inhalers properly and with the proper techniques. And we should be teaching frequently to this patient, and we should be adequately counseling them for smoking cessation, and appropriate vaccinations has to be done, along with pulmonary rehabilitation. A protocol has to be implemented for these patients. So basically, COPD treatment completes with this. So basically, symptom relief as well as a comprehensive approach with smoking cessation, vaccination, all these things has to be combined for a better outcome. So a few words about non-pharmacological treatment as we discussed. So basically, smoking cessation and vaccination are the important aspects of the non-pharmacological treatment as per the current gold guidelines. So group A. So any patient who is walking into our OPD with COPD, then probably he has to be included in the pulmonary rehabilitation session, and smoking cessation has to be implemented or has to be insisted for each and every patient, and vaccination also has to be implemented. And it is more so for the group B, C, and D patients. Few words about smoking cessation. Smoking cessation has the greatest capacity to influence the natural history. So smoking cessation is the only modality or only treatment modality which has shown a mortality benefit. So definitely the slowing down of the progression of the disease is clearly shown with smoking cessation. And it is very difficult to achieve smoking cessation in every patient. So the data says that only up to 25% of the patients can be achieved with smoking cessation, even with repeated counseling. So each and every review patient has to be insisted on smoking cessation, and if needed a psychological assessment and psychological counseling, behavioral therapy and group therapy, all these modalities can be tried. And if at all, if needed, nicotine replacement therapy and other pharmacological agents may be used with caution, because these agents may have significant side effect profile. So most of them it is behavioral therapy and smoking cessation clinics, and psychological counseling along with medications can help. So the well considered approach is ask, advise, assess, and assist and arrange type of uh, treatment and approach has been well proven for smoking cessation. We all know that. And a few words about vaccination. So pneumococcal vaccination and influenza vaccination has definitely shown to reduce the disease severity in terms of repeated infections and reducing the infections. So pneumococcal vaccine has reduced the mortality in almost 30% of the COPD patients. And influenza vaccine also, again, the risk reduction is almost close to 20 to 30%. And vaccination schedule is concerned, if the patient is not vaccinated before 65, then both the vaccines, that is the pneumococcal vaccine, both has to be given. That is the conjugate vaccine 13 as well as the polysaccharide vaccine 23 in 6 to 12 months interval. Provided if the patient has received already the 23, that is polysaccharide vaccine, then probably a 1 year gap should be given for PCV 13. And the patient has received a 23 vaccine before 65 age, then probably the PCV should be given in first, and after 65 years, then after 6 to 12 months interval, then 23 vaccine has to be given. And as all of us know that the influenza has to be repeated annually according to the guidelines. Coming back to our patients, our patient has been started on appropriate medication. He was vaccinated, and with repeated advice, he stopped smoking also. But despite the patient had little symptomatic improvement, he's still desaturating on exercise. He's got 82 to 85% of oxygen on exercise. So an echocardiography was done for this patient. He has got adequate LV ejection fraction, but the RV systolic pressure is significantly high, 56, and RV strain. At this point, the pulmonary angiogram was done in terms of significant disproportionate RV strain. Peripheral segmental pulmonary embolism was as expected in this particular patient. So this is an important comorbid condition, or important important condition which is easily missed in these type of patients. So we should give importance to this pulmonary embolism also. So if you look at here, the pulmonary embolism is notoriously clinical diagnosis in patients, and pulmonary embolism is well known. And other comorbid conditions like cardiovascular, ischemic heart disease, arrhythmias, peripheral vascular disease, hypertension, osteoporosis, anxiety, depression, and lung cancer, gastroesophageal reflux disease, and bronchiectasis, obstructive sleep. These are all some of the comorbid conditions which are commonly associated with COPD. So these things also has to be optimized along with the optimization of the treatment, disease per se. And in terms of so they share the common risk factors, as all of us know that smoking, ischemic heart disease, as well as the COPD. There is a common risk factor, and most of our COPD patients may have underlying hidden cardiac conditions to optimize the treatment. So the patient is not improving with your appropriate treatment, then look into these aspects also. As shown in here, these COPD patients may have heart failures, arrhythmias, and ischemic heart diseases, pulmonary artery hypertension. Also, again, in India, it's very common. So all these factors has to be considered and has to be optimized. And in fact, if you look at most of the COPD patients die of ischemic heart disease or a cardiac problem rather than COPD kills them before. Coming to our patient again, patient has started on heparin based on the findings. And, after a few days of heparin, then he was overlapped with optimized anticoagulant agents, and he was started on low dose of also optimized RV. However, this patient had to have coming out of bed after started smoking again. He has got a very poor nutritional status, RS update, and he's anemic also. And the pH is not, even though the pH is compensated, he's got a chronic hypercapnia, 52 of carbon dioxide. and hypoxia also. What next can be done for this patient? What next can be added for this particular patient? We all know that in some patients, important component of treatment. Every part of the treatment, after optimizing the comorbid conditions, still the patient is not improving. So, programmed exercise training and home oxygen therapy along with smoking cessation, inhaler techniques, comprehensive treatment has to be comprehensively arranged for these type of patients. And pulmonary rehabilitation is important aspect at this point of time for these type of patients. So what rehabilitation actually does is, if you look at these COPD patients, they have the reduced activity, they are isolated from the society, so they feel lot depressed, which again causes breathing restlessness, and this is a vicious cycle which is going on. So what rehabilitation basically does is it's a mental and psychological improvement of well-being, even though there is no maternity and even though there is no symptomatic relief based on the this muscle activity and improve the activity of daily living. So there is a central desensitization of dyspnea happens because of a good rehabilitation program, and the patient has got decreased the anxiety and depression, and there is a reduction in dynamic hyperinflation, which is an important pathophysiological change for the dyspnea, and improved skeletal muscle function because of the exercise will give a feeling of well-being and improved activities. So rehabilitation has to be implemented in every patient, each and every patient of COPD, irrespective of the stage of the disease. A group therapy like this can be arranged for all our COPD patients, which can give a better impact in the treatment aspect. And a few words about oxygen therapy and NIV in COPD. So long-term oxygen therapy should be considered in those patients who have significant hypoxia at rest, CO2 less than 55 or saturation of 88 at rest, or with the exercise desaturation less than 88, or if there is a significant right heart strain or erythrocytosis, then these patients has to be considered for home oxygen therapy. So to keep this at 90%, so long-term home oxygen therapy is one of the, and which has also shown to be improving survival also in some of these patients. So appropriately, this our particular patient has to be given appropriate, home oxygen therapy. He is the right candidate for home oxygen therapy. And in some of the patients, home NIV, that is going to be beneficial, especially in those patients who have got a chronic refractory hypercapnia. Along with rehabilitation, along with oxygen therapy, the home can also be tried these type of patients. And this is one of our COPD, not our patient, this is one of the as shown here, is not improving, and CT scan showed endobronchial obstruction here. PET scan was showed, PET scan showed the big mass lesion, PET uptake here. Bronchoscopy showed, confirmed that bronchogenic mass lesion here, which was biopsied and confirmed as bronchogenic carcinoma. So I am saying this here is the bronchogenic carcinoma is also an important comorbid which can coexist and it can be easy because these patients actually will not, unless otherwise we do a CT scan and find out these lesions, then probably we are like. So bronchogenic, because the common risk factor again, so cardiovascular disease along with bronchogenic carcinoma also can. Coming to our patient again, this patient's lung window showed that emphysematous bulla on the right lung, both lungs, more on the right side. If you see that there is heterogeneous emphysema on the right upper lobe with a lot of bullae, both sides being more on the right side. So this patient has got an upper lobe predominant emphysema, more on the right side. He's got a very limited functional lung. You can see most of the bullae are very big and compressing on the rest of the lung, which can cause, which is the important reason for this patient's activity limitation and persistent symptoms. So can we offer more for this patient? Here comes the lung volume reduction. So in selected patients, emphysema and significant patient, which is compressing the normal lung and which is causing symptoms, then these patients can be optimized or can be offered a lung volume reduction surgery, either bronchoscopically or surgically, to achieve a volume reduction or to remove the non-functional lung so that the functional and can be salvaged. So either surgical or bronchoscopic lung volume reduction surgery can be considered as an interventional thing in these type of patients who are refractory to standard treatment. So these are some of the examples.
म्यूट करना
There you can see
दानी डिस्टर्ब
volume
करती
there, paper treatments available for the lung volume reduction, and
है सर्जिकल ऑप्शन है तो बोला
valve
क्या लास्ट
here, the bronchial valve here.
चलो म्यूट हो जाता है
There's a small video I can show you here that how the bronchoscopic volume reduction is done here. Basically, there is the bronchus size is measured with the occlusion balloon.
Santakumar, you unmute yourself now.
Yes, sir. Yes, I unmuted. Am I audible, sir?
Yeah.
So this is how the valve is.
And you're audible.
So this is how the valve is introduced actually. So basically this is a one-way valve which can allow the air entry in the expiration and which will not allow the inspiration and which will allow the secretions to be drained adequately. So this is just some of the examples. Volume reduction surgery. These are advanced to treatment.
These are the questions. Surgical options.
Either bronchoscopically or surgically can be offered. So that is the take-home point here. And if at all the patient has got a large bulla, then a surgical bullectomy also can be offered. And finally, coming to our patient again, the patient was given adequate nutritional and rehabilitation. Patient was sent home with home oxygen and BiPAP treatment, and he refused LVRS treatment. And however, the patient was offered a bullectomy. Bullectomy patient refused, and still he has got progressive worsening of FeV1 6-minute walk test, and patient is still on home oxygen and BiPAP. So the available option can be viable option can be lung transplantation for this patient. So basically, to summarize, COPD management, smoking cessation is the key as a risk factor reduction, and pharmacological therapy has to be optimized, which can reduce the COPD symptoms, reduce the frequency and severity of exacerbations, and improve the health status and tolerance. And vaccination decreases the incidence of lower respiratory tract infection and thereby the exacerbations. And pulmonary rehabilitation is important part of the treatment, which improves the symptoms and quality of life, physical and emotional participation of everybody's activities. And in patients with severe resting chronic hypoxia, long-term oxygen therapy and home NIV therapy can improve the survival. In patients with severe chronic hypercapnia, that is a long-term home NIV can be a good option. And in selected patients with advanced emphysema, there is heterogeneous emphysema, which is refractory to medical care, surgical or bronchoscopic interventional treatment may be beneficial. And palliative approaches are effective in controlling symptoms in advanced COPD, and lung transplantation can be a viable option. So with that, I end my talk, and once again, I thank everybody for giving the opportunity and close attention. Thank you.
Hello. Yes. Thank you, Dr. Shantakumar, for such a lucid presentation. It was very well explained, right from start to end, covering various options and management heterogeneity, also including the surgical options for COPD. And we have few questions. I think we'll take the questions in the end. And we would go to the second talk now by Dr. Bharat Kumar. He is an critical care consultant in Apollo Hospitals, Chennai. He has done his MD anesthesia from PGI Chandigarh, and then he has done his critical care training from the National University Hospital, Singapore, and Sunnybrook Health Sciences Center in Toronto, Canada. He's currently working in Apollo Hospitals, Chennai, as a critical care consultant. Over to you, Dr. Bharat Kumar.
Hello, hi everyone. Thanks to Dr. Narasimhan, Dr. Harish, and all the organizers. Thank you so much for this opportunity. It's an absolute pleasure to be here. I'll share my screen if that's okay. Just a second. Can you see my screen?
Yes, sir.
Thank you. Thank you so much.
Yeah. Before I start, Bharat, may I request all the people to mute themselves, please, excepting the speakers. Yeah, Bharat, you can start.
Thank you. So my topic that was assigned to me is actually weaning in COPD. So I may not be focusing on the initial ventilatory management of COPD patients, and there is actually quite a bit to cover there too. Happy to come back and give a talk at some point on that. There's a lot of challenges with the initial ventilation, and how we should proceed with that. I'm mostly focused on the latter half, that is the weaning aspect in COPD, and that is what this talk is going to be focused on. No relevant conflicts with this respect to this talk. That's my email address. You can send me email for questions or slides. Apart from questions that I'll take obviously at the end of this talk. That's my Twitter handle, and you can follow me for academic content. So in this talk, we will be covering about definitions and terminologies, general considerations when you're weaning any patient with respiratory failure, then the approach and principles involved in that, specific considerations with respect to COPD, and then of course we will summarize our discussion. I have quite a few slides, so at some point if we're running out of time and we would want to move on or skip some slides, I'm very happy to do that. I was not sure how much time I would have, so I will gladly stop if needed at any point, but I'll try and get through most of the content. Thank you. So weaning is really the process of gradually or abruptly withdrawing ventilatory support, and this has two related steps. One is really the discontinuation of the mechanical ventilation process, and then there is removal of the artificial airway, whether that is the endotracheal tube or whether that is the decannulation of the tracheostomy tube at a later point in time. And this was one of the earliest conferences that was held, or in terms of for defining and terminologies as related to weaning. This was a multidisciplinary conference from several societies coming together to define all aspects as related to weaning. And one of the key questions they addressed was what is really the schema, or what is the patient flow once they get admitted up until the point. And this in this conference was defined basically as patient is admitted, we start treating them for acute respiratory failure, whether it is related to COPD or not COPD. At some point, the disease has resolved and we suspect that they may be ready for weaning, and then we assess their readiness to wean. We perform what is called as a spontaneous breathing trial. Then they proceed on to extubation. This is the straightforward, smooth course. Several patients are unfortunately going to get reintubated, and then either they get discharged or they die. This conference, our task force went on to define several important aspects as related to weaning, regarding the pathophysiology of weaning, regarding reasons for failure, how an SBT should be done, and so on. And this really is the guiding document, which has then led on to much more research in this topic. Now, what this conference did was they classified the weaning process based on this consensus view and based on the available evidence at that point into simple, difficult, and prolonged weaning. So simple weaning is when patients proceed from initiation of weaning to straightforward successful extubation on the first attempt after the first spontaneous breathing trial. They define difficult weaning as those who fail the initial weaning and require up to 3 SBTs or up to 7 days. And then any attempt or any effort beyond that would actually qualify as prolonged weaning. Fortunately for us, 80% of patients fall in the simple weaning category, and the bulk of them will actually leave the ICU, leave the hospital quite all right. But COPD and COPD patients, especially the ones with moderate and severe disease, are going to be mostly, at least a lot of them are going to be in the difficult and prolonged weaning categories. And a lot of challenges that we face are going to be related to that. And I will be addressing several of those in today's talk. There are other terminologies to know when we say that somebody has failed weaning. What we mean is that they've either failed an SBT, a spontaneous breathing trial, and I'll explain what an SBT is, or they need re-intubation or reinstitution of ventilatory support within 48 hours of extubation, or they die within 48 hours of extubation. With diseases such as COPD, there is also this tendency to extubate them even when they're not completely ready to NIV. And there was this dilemma about what we would call them or how would we define them. So when there's ongoing need for NIV, we call that as weaning in progress. And these are some of the terminologies that this task force actually came up with. Now, general considerations for weaning, really weaning is a balance between the load that the ventilatory and respiratory system can take versus the capacity that it possesses, right? So early on in a disease phase, the load or the demand is much more, and therefore they need mechanical ventilation. And hopefully, as recovery progresses, spontaneous ventilation is possible, and we're able to get people off the ventilator. That is, the capabilities increase as compared to the demands. And there are several demands and load factors. We have pressure-related demands, which is related to compliance of the lung and the resistance of the lung. We have ventilatory demands related to alveolar ventilation, the amount of CO2 that the patient is producing, the amount of oxygen that they're consuming. And there are imposed loads because of an infection or a fever or whatever comes along. And then there are capabilities that the respiratory or the respiratory and the neuromuscular system have, which is really the neural drive and the muscle strength. And there is a fine balance in critical care throughout and the pendulum keeps swinging based on the illness phase of the patient. But as they recover, we hope more and more that they would move towards the capability side of things. Now, whenever we talk about weaning a patient, three things need to happen. The first thing is that the problem that led to the mechanical ventilation must either have become resolved or should be adequately controlled. We then need to have certain measurable criteria that suggest that a patient is ready for weaning, and then they need to demonstrate that they can breathe by themselves, which is what we call as a spontaneous breathing trial. I will talk about each of these things. The first aspect is really that the problem that leads on to mechanical ventilation must have resolved. In our case, for example, with COPD, the acute exacerbation episode should have either come under control or should be resolving. This means that the bronchospasm has reasonably broken, the CO2 retention has cleared up to a large extent, the respiratory acidosis and type 2 failure have settled down, the PFR has improved, and so on. And this is similar to other diseases. So if you're intubating somebody for a pneumonia, they should have improving oxygenation, overall clinical status should have improved. If it's a septic shock, we should have source control, the hemodynamics should be better, and so on and so forth. Essentially, the disease process that made them go on to the mechanical ventilator should either be resolved or controlled. This is the first and foremost thing that we need to consider when we are weaning any patient. Related to this is the fact that the patient should also be fully awake and alert and should have a reasonable cough response and manageable tracheal secretions, because these are also reasons for failure. So these things in parallel need to have improved as well. The second thing we look at when we're weaning is, are there certain criteria that can predict if somebody will wean off the ventilator? There are criteria, and they all have variable performance, but these criteria have been divided into ventilatory performance, ventilatory drive, work of breathing, and then adequacy of oxygenation. And I'll talk about each of this. So when we're talking about ventilatory performance and muscle strength, basically a few things. All of this is, I think fairly obvious and common sense. The patient should be able to take a tidal volume of more than 4 to 6 ml per kg of their ideal body weight on a spontaneous mode. They should be breathing at less than 35 breaths per minute. These two variables, that is the frequency and the tidal volume, have been put together into an index called the rapid shallow breathing index. And this should be between this range of 60 to 105 breaths per minute per liter. The predictive value of RSBA is very good when the pretest probability is on the lower side. That is, if the pretest probability of success is low, and then the RSBA is in that range of 60 to 105, then your post-test probability goes up. But if the patient already looks very good and ready to wean and ready to come off the tube, that is, the pretest probability is already high, then the RSBA doesn't add much. But this is one of the most commonly used indicators, and that's the reason I wanted to emphasize on the role of the rapid shallow breathing index. Then we look at the ventilatory pattern of the patient, whether this is a synchronous and stable pattern, and this is just a visual examination, because one of the major reasons for failure of weaning, whether it is COPD or not, is really dyssynchrony or asynchrony between the patient and the ventilator. In other words, the patient and the ventilator are fighting each other. That's the common language usage of the term, but really it's a synchrony issue. One of the other parameters that we look at is something called the maximum inspiratory force, or the pressure in the first 20 seconds of a patient's spontaneous breath. And this needs to be at least -20 to -30, should perhaps be more than that. This is also a very important indicator, not just in COPD, but also when we're ventilating patients with myasthenia gravis, Guillain-Barré, and so on. So these are some of the ventilatory performance criteria that we look at. The next thing that we look at is the drive, and this is talking about the neural drive. There is a measure called the P.1, which is the pressure generated in the first 100 milliseconds. And this should be between 0 to -2 normally. It can be more, but if it is less, if this drive is very less, then the chance of success is poor. We can also measure the work of breathing. Measuring actual work of breathing is pretty complex, and I won't go into it. But there is a substitute called the CROP index, which puts together a variety of respiratory parameters: compliance, the respiratory rate, oxygenation as measured by the PaO2 to the alveolar oxygen PaO2, the capital AO2, as well as the inspiratory pressure. It puts together all of this, and the magic number, if you have to remember, is 13. It should be more than 13. So these are some of the criteria that help you tell whether somebody is going to successfully get weaned off the ventilator. Then we also look at the adequacy of oxygenation, whether they have a PaO2 of more than 60 millimeters at an FiO2 of less than 0.4. We can look at that P to F ratio, and that should be more than 200 in somebody who's recovering. We can also look at the arterial to alveolar oxygenation ratio, or the gradient, and this ratio should be more than 0.47, and the PEEP should be less than 5 to 8 centimeters. All of these are essentially parameters that are telling you that the patient is improving. Whatever led them to get onto the ventilator is improving, and we are in a reasonably good space to move on with weaning. Then we move on to the third thing. So as I was telling you, the patient should be, their condition that led on to ventilation should be better. We should have some predictors that suggest that they can be weaned, and then we carry out what is called as a spontaneous breathing trial. This is the most important component. An SBT is really a simulation of a post-liberation environment. So we're just simulating this before we take the tube out. What we do here is you put the patient on a low pressure support, which means a PEEP of 5 and a pressure support of 6 or 8. Or you put them on a T-piece, and then you let them be on this for 30 to 120 minutes if they tolerate it. Now, if they go through the whole 30 minutes, we call that an SBT success. But in that period, if they have any evidence of decompensation, whether that is worsening of oxygenation, whether that is sweating, tachycardia, dysrhythmias, clinically, if they look uncomfortable, we call that an SBT failure, and then we go back onto a control mode or to a pressure support mode with a higher support. Generally speaking, apart, I mentioned several indicators such as RSBI, P.1, and so on, but the best predictor of success generally is a spontaneous breathing trial. So if patients can do an SBT well, the chance of them getting off the tube and staying off the tube is very, very high. So it's a very sensitive and very specific test that can actually tell you whether a patient is going to do well. Now, if an SBT fails, then we need to think about reasons for failure. And all of these reasons for failure are common, not just for COPD, but for other causes of acute respiratory failure as well. There are certain specific features of failure in COPD, which I will be addressing. The first reason for failure is generally the cardiac status, and whether, COPD itself can come with concurrent comorbid cardiac illness, but also the weaning process can induce some cardiac failure, and I'll address that. So cardiac status includes both systolic and diastolic failure. With systolic failure, I think we all understand why that can hamper weaning. What is often missed is the fact that some of these patients have a grade 2, grade 3 diastolic failure, and they're so much dependent on that minimal positive pressure. If you remember pulmonary physiology, positive pressure has favorable effects on the left ventricle, right? So it can actually reduce the afterload and so on. So the minute you withdraw that positive pressure, these patients can go into what we call a weaning-induced pulmonary edema. So this is one of the commonest reasons for failure, and we can actively work, and it's a reversible or it's an addressable reason for failure. The second thing to look about is the acid-base status, and this is a particular problem in COPD. As you all know, these patients have a chronic respiratory acidosis. They have a CO2 which is 45, 46, and they have a bicarb that's compensating. Now, if you overventilate them in the ICU and drop their pH down to an alkalotic range, drop their CO2 down, whether it's respiratory alkalosis or metabolic alkalosis, they stop triggering. Their respiratory drive comes down, they stop triggering, And this is actually a big reason for failure in COPD patients. So basically, you would have to go back, underventilate them a bit, let the CO2 rise, and then help them to trigger and come off the ventilator. And often in the ICU, when we have newer trainees, we see this problem that, they ventilate them like any other patient and drop their pH down. So this is something to watch out for. Independently, electrolyte abnormalities such as hypokalemia and hypomagnesemia reduce the neuromuscular strength and therefore contribute to weaning failure. But also when you create an alkalosis, that also worsens the hypokalemia and hypomagnesemia, and that then also results in ventilatory or weaning failure. Endocrine abnormalities such as hypothyroidism, I think you're all very familiar with this, and the interaction between hypothyroidism and COPD and type 2 respiratory failure. So this is also a big reason for weaning failure. There are other reasons for failure. Without going into great detail, if they're still under the effect of sedatives or neuromuscular blockers, antibiotics such as aminoglycosides cause neuromuscular failure or weakness. If you're overfeeding them, this is rarely a problem. And if they're in a highly catabolic state, for example, they have a severe COPD, but now have come in a septic shock from urinary tract infection, they tend to be in a highly catabolic state, which results in a rapid loss of muscle power. There are psychological factors which can cause weaning failure. And then there is something called ventilator-induced diaphragmatic dysfunction. When patients are chronically or at least for longer terms ventilated only with controlled ventilation and we don't allow the diaphragm to work, that results in diaphragmatic dysfunction and is associated with weaning failure. There's a lot of research going on into how ventilator-induced diaphragmatic injury happens, and there is enough and more data emerging to say that with more and more diaphragmatic dysfunction, there is a reduced likelihood of success with weaning. This is just a table that summarizes all of the causes that we went through. I won't go back into it, but suffice to know that you need to run through all of these causes in your head whenever somebody fails a weaning attempt. So now we've spoken about how do we approach weaning, what is the normal trajectory of weaning patients, what happens with an SBT, what do we think are the reasons when somebody fails. Now, what do you do next when somebody fails? The first thing to do is rest them for the next 24 hours, ideally on a reasonably good support mode. Don't make them work after they've failed an SBT. Give them rest on the ventilator with partial or full support for 24 hours. Focus on the ventilator settings. Make sure that they're in a comfortable ventilator setting, whether that's the trigger. Make sure that they don't have auto PEEP if it is COPD, or minimize the auto PEEP. Evaluate and address all the fixable issues that we spoke about, whether it's cardiac failure, magnesium, potassium, whatever it is. Go back and address those issues, and then try the SBT again in 24 hours. Every 24 hours, you can try an SBT. If they don't get extubated in the 7-day period that I was mentioning to you, then they move on to what we call difficult weaning or prolonged weaning. So this is a schema of what conventionally happens. So you put the patient on mechanical ventilator. You hopefully the condition gets, whatever reason they were intubated for, gets better. Do a first SBT, extubation, most straightforward pathway, which is what I was telling you 80% of our overall critically ill patients go through. Then you come to this complex area in the middle where they're having recurrent SBT failures, or they're succeeding in one of those attempts, or you may have to extubate them to NIV in order to facilitate the weaning, and we will talk about NIV in some detail. But if they fail all of this, then we go into the prolonged weaning or into a permanent weaning failure status. So this is generally the approach that we think about. We need to keep doing these SBTs and think about at each stage what are the causes for failure. But despite addressing all these causes, if they go into this end phase, then we have to think of a different strategy for weaning them. And typically then we would consider moving them to a weaning center or a long-term care center. Now, this part here talks about not using curative NIV, and I will address this in a bit more detail. Just remember this, and we'll come back to this part. We'll talk about prophylactic NIV, we'll talk about curative NIV, we'll talk about facilitative NIV, all of that very quickly in the next few sections. Now in COPD, what else do you need to consider? We know from the previous talk that, we learned a lot of COPD in the previous talk, and you're all experts in it. So this is a chronic illness state with multiple admissions and deconditioning. So it's very important to have early goals of care discussions with these families, which means, considering not intubating them and just trying to manage with NIV initially, or if they get intubated and if they fail their first SBT, start having conversations with family, are they still keen on pushing on, trying further therapies, whether they want to, what stage of their life are they at, what are their values, what therapeutic options are still left, what is their existing quality of life. Do we want to push them towards the prolonged weaning phase? Should we offer a tracheostomy? So we need to have all of these goals of care discussions, and doing this as a joint team, that is pulmonary and intensive care, makes the most sense, and that is the approach that we take at our site as well. The general approach to weaning is as before, as what we have described. Some specific concerns with COPD when they fail is there still ongoing increased airway resistance, and can we optimize further the bronchodilator and steroid therapy? I won't go into detail on this. Dr. Shantakumar has gone in extensive detail and nicely explained what are the alternatives available to us at that point. But this is always a question, and somebody is failing, is airway resistance still the main reason that they're failing? We also worry again about the diaphragmatic dysfunction component, and this is actually supposed to be more in COPD because the dynamic hyperinflation and the air trapping itself makes the diaphragm flat, itself causes more diaphragmatic muscle fiber damage, and therefore leads on to more diaphragmatic dysfunction. There may not be, so what we can address in this component is really avoiding hyperinflation, paying a close attention to the intrinsic beat, and trying to see what we can do to minimize that. In critically ill patients, the third component that comes up is what we call as critical illness polyneuromyopathy. And anybody that's worked in an ICU will know that when patients are in the ICU for 7 days, 10 days, when they have COPD, but also on top of that, a catabolic illness such as septic shock, they tend to have huge amounts of muscle damage and nerve damage. They have transmission problems, they have demyelination, they have muscle injury, and all of this contributes to a critical illness polyneuromyopathy state, which means that they're so weak that they can't even trigger the ventilator. So this is a particular problem for all our critical illness patients, but this becomes a special problem when you have COPD patients who are already frail, who have had previous multiple admissions and are now coming in for a related, either just an exacerbation of COPD or COPD is in the background and they have a new problem. So this is a special consideration again in COPD. Now, are there any predictors of weaning failure specific to COPD? Not really, there's not too much data, but there's just a couple of papers that I want to quote. This is a small study of 30 odd patients published as only an abstract, which looked at the fluid balance that the patient had in the 48 hours prior to the first SBT. And they were able to show in the small study that the more positive your fluid balance was in the 48 hours running up to the first SBT, the more likely that you would fail a weaning attempt. So whether aggressive diuresis needs to be done, or whether this is something that we can optimize, is something to think about. This is a very old paper from 1994, looking at all the predictors of successful weaning in COPD patients, especially when they have a prolonged ventilation. And they basically used a multivariable regression model. What they found was two predictors: the carbon dioxide and the maximum inspiratory pressure seem to be the biggest predictors of have the biggest predictive value really for ventilator weaning success or failure. We then have this more recent paper from 2016 that looked at what are the predictors of weaning success or failure, and they studied number of factors: malnutrition, electrolyte imbalance, myocardial ischemia, and so on. But only two parameters stood out in their multivariable analysis. One was a TSH of more than 2.65, so not even the 5 cutoff that we normally take. So even what we would probably think of as a minor, or not even what classifies as hypothyroidism, really would impair any thyroid dysfunction, would really impair weaning, and an impaired nutritional status seemed to impair weaning. And these are the two important factors that they were able to show as predictors of weaning failure. Again, things to think about when you are dealing with a patient that's not able to wean or come off the ventilator. Now we will focus on certain special questions or special considerations in COPD. And the first one is really NIV. And this is very, very crucial, very important, both to intensivists and pulmonologists. The first question is, can NIV be itself a weaning strategy, what we call facilitative NIV, as I mentioned earlier. And this is one of the best papers on this. It's actually a Cochrane review from 2013, but there have not been too many studies after this. And I would recommend this paper for all of you to go and read. Basically, they evaluated whether a strategy of extubating to NIV versus an ongoing weaning on the ventilator. They compared this. They included all trials that asked this question, and patients with all causes of ARS are included. But most important for you is that almost all the trials here were focused on COPD patients. There were 15 RCTs and one quasi-randomized trial. The primary outcome that they looked at was all-cause mortality. They had 994 participants across the 16 trials, and 2/3 of these were COPD patients. The trials, of course, had different NIV strategies, but they all were extubating to NIV versus ongoing weaning on the ventilator. And look at these numbers. So when you look at the mortality, the relative risk is 0.36. So in favor of NIV. So 64% reduction in mortality when you extubated to NIV instead of ongoing weaning on the ventilator. And the overall mortality, that is, if you take all the patients, the risk reduction is 19%. The relative risk was 0.81. So very impressive mortality reduction. The quality of evidence was moderate. It was not bad. So strong signal supporting the role of an earlier extubation to NIV instead of just continuing weaning on the ventilator. Similarly, if you look at other outcomes, whether it's weaning failure, the relative risk is 0.63, whether it's nosocomial pneumonia, again, all of it is in favor of NIV. There is a huge reduction in the risk of pneumonia when you get these people off the ventilator, reduction in the risk of weaning failure, reduction in the risk of reintubation. So strong favorable impact of NIV, and the evidence obviously applies mostly to COPD because most of these trials really included COPD patients in the ICU. Then there is this particular meta-analysis that generally looks about facilitative NIV for all critically ill patients. This is not just COPD, and this is not just acute respiratory failure. Again, without going into water network meta-analysis, consistent evidence of benefit when you go to a facilitative NIV. So look at the relative risk here, all of them, whether you convert, the comparisons here are NIV versus conventional oxygen therapy, HFOV versus conventional oxygen therapy, high frequency plus NIV versus high frequency. Whatever the mode, whenever you add NIV or HFOV, there seems to be HFOT rather, there is a clear benefit in terms of reintubation rate as well as the short-term mortality. So some signal again that extubating to NIV or HFNC seems to be beneficial with regard to both of these outcomes for all critically ill patients. We then look at the third question. I was talking to you in that previous slide about rescue NIV. That is, when patients are extubated, they look okay initially, but then in the first 48 hours, they stop, they look like they're failing. Should we put them on NIV? So this trial asked this particular question, that is, they were extubated to oxygen. Within 48 hours, they fail. Should we now try NIV on them? Okay. So this trial had about 200 odd patients. Baseline characteristics were similar, and they had about very small proportion of COPD patients, only 23. They included all other critically ill patients. And what did this trial show? They actually found that when you give rescue NIV, that is, once they already failed, if you try NIV, the mortality was much higher. 1.78 was the relative risk of death, much higher when you try NIV. But in the post-hoc analysis of the 23 patients with COPD alone, when they looked at that group, NIV did not seem to cause any problem, and the mortality rate of reintubation was actually lower. But the only problem is there are only 23 patients, so it's very hard to draw conclusions. But generally speaking, in the intensive care unit, we don't recommend rescue NIV when somebody is clearly failing within 48 hours of extubation. Then there are other questions that we can address, and very important to COPD again, does the mode of what we use for spontaneous breathing trial matter? I mentioned earlier that we do pressure support or TPs. That one particular mode is one particular mode superior for a spontaneous breathing trial. And this meta-analysis tried to answer this particular question. They had about 17 odd trials, and when they compared pressure support to TPs on SBT success, that is the success of a spontaneous breathing trial, no difference. When they compared it on extubation success, which means patients get extubated and stay extubated for 48 hours, a slight benefit in favor of pressure support. So no difference on SBT success, but some favorable benefit when you look at extubation success. So pressure support seems to be having some advantage over a TP's SBT. And it also makes sense because on pressure support, you're giving some support, whereas with TPs, they're actually breathing, the tube is in, and they have to breathe against the resistance of the tube without any support. So it does seem to make sense that SBT success might be higher with pressure support. This is just a forest plot of the same. When they include all the trials, no difference. The diamond is bang in the middle, which means that there is no benefit or no difference between pressure support and TPs. But when they exclude one low quality trial, it seems to favor pressure support. So overall, the data seems to be suggesting that pressure support is a superior mode for an SBT and for extubation success as compared to TP's trial. There are specific questions on regarding modes, whether we should use proportional assist or NAVA. What I will do is I'll come back to these two if we have time. I want to cover two other questions, and then if Dr. Harish and Dr. Narasimhan feel there is time, I'll come back to these two modes. Let me just skip a few slides. Okay, so I want to talk to you about ECOR, and you all might be familiar with this concept, which is basically extracorporeal carbon dioxide removal in acute exacerbation of COPD. So is ECOR helpful in weaning? Is ECOR helpful at all in COPD patients? And this is a very interesting question. For those of you that are not familiar, ECOR is basically a technique of extracorporeal CO2 removal, which basically means you take the blood out of the patient, you remove the carbon dioxide and return the blood, okay? So because carbon dioxide is a highly soluble gas, you need a very low flow, just 300 ml to 1 liter per minute. You can cannulate the femoral vein in the femoral artery. There will be a drainage cannula. The blood will come out of the femoral artery. It will go into a membrane lung, which will remove the CO2. It will return the blood through the venous cannula here into the femoral vein, and it clears the CO2 and sends it back. So we have arteriovenous ECOR, our venovenous ECOR. So this is the simple mechanism of removing CO2. Now, is there any physiological rationale to do that? It does appear that there would be, because if you look at it, in COPD exacerbation, you all know the pathophysiology. There is dynamic hyperinflation, the muscle fatigue, there's ventilatory pump failure, there's rapid shallow breathing, there's increased CO2 production and a decrease in the elimination, and this results in respiratory atherosclerosis. Now, you all know this. By applying ECOR and getting the CO2 out, you decrease the alveolar ventilatory demand naturally, you lower the respiratory rate, you increase the expiratory time. All of this is good stuff for COPD, and you know this. So this in turn reduces the dynamic hyperinflation, decreases the muscle fatigue, and therefore improves outcomes. This is the rationale. And this is why ECOR or extracorporeal CO2 removal is supposed to help. Is there any data on this? The data is unfortunately limited to case series or non-randomized designs. So we can't make a conclusive assertion at this point, but there are several RCTs that are currently enrolling, and they're looking at the role of ECOR in various stages. That is, pre-intubation, can we manage patients with NIV and ECOR? Then post-intubation, can we manage, get them off the ventilator with NIV and ECOR? So all, the whole spectrum of ECOR use is being studied in several trials. And I think in the coming 3 to 5 years, we're going to have lots of exciting data on whether this is doable or not. And because the circuit is simple, this is an easily doable strategy in a lot of setups. The cannula is small to place. It's not a very cumbersome procedure. This is not like a full-fledged ECMO. So this is something that is very attractive, but we need to prove that it works in randomized controlled trials. Then I will also answer the specific question of acetazolamide, because I think respiratory stimulants is always controversial, but also a favorite for several people. I will only focus on a couple of issues here. This is a big trial comparing acetazolamide versus placebo on the duration of invasive ventilation among patients who have COPD. So this was a French multi-center trial looking at 15 ICUs, 382 patients were randomized, 380 were included in the final analysis. What they did in this trial was every morning an ABG would be done. If the patient was having any alkalosis, they would be randomized to acetazolamide or placebo. The acetazolamide dose was 500 mg BD or 1000 mg BD, or they would be randomized to placebo, and this was done throughout their ICU stay. And patients needed to have an acute exacerbation with metabolic alkalosis on their ABG done in the morning. That is the way the trial was conducted. The baseline characteristics of the patients were similar. You don't need to worry about the slide, it's a bit busy. Just to highlight that there were no differences between the two groups. Their baseline pH was similar, their PCO2, bicarbonate were all similar to begin with. Unfortunately, the trial did not show any benefit on the primary outcome of duration of invasive ventilation, although there seemed to be a trend in favor of in the duration of ventilation per hours. This was not statistically significant. No improvement in any of the secondary outcomes. So really no benefit of acetazolamide. Also seen in this Kaplan-Meier curve here, which shows that the probability of being weaned was not different between the acetazolamide arm and the placebo arm. One of the criticisms of this trial has been, why should you give acetazolamide every day from the start to end? But that is the trial design that the authors had chosen. So every day that a patient had alkalosis, they would give acetazolamide or placebo, and that's the comparison that they did. There is an abstract publication alone meta-analysis which looked at or 3 trials of acetazolamide and outcomes. And again, if you look at, you don't have to worry too much. You just need to focus on the diamond. They look at 3 outcomes: duration of mechanical ventilation. You can look at the diamond crossing the middle line, so no benefit. Length of ICU stay, again crossing the middle line, no benefit. All-cause mortality, no benefit. So no real benefit with acetazolamide. It appears in COPD. I've not gone into other respiratory stimulants, but at least in our ICU, typically we don't use acetazolamide. So that's what I have to talk about. If there is time, I'm happy to talk about the newer modes. But if not, I can move on to my summary slide. Dr. Harish and Narasimhan, should I go on or should I?
You can go on, Harish, for another 10 minutes. That's not a problem at all. You can just go ahead with the new modes.
Sure. Thanks, sir. Okay, so I'm going to move back on my previous slides because these 2 are good modes for you all to be familiar with. I will try and be a bit quick through it. Okay. So do newer modes of ventilation, these are not very new, but they're relatively novel modes. Do they help in weaning? See, when you may all be familiar with pressure support. In pressure support, you connect the patient to a ventilator, you set a PEEP, whatever the PEEP is, 5, 8, and then you set a particular support, 10, 12. That support is fixed unless you change it. So for a given breath, the patient will have the same support. And sometimes the patient may take a deeper breath, the same, or a more forceful breath, and the same support will be provided. Sometimes the patient may take a smaller inspiratory effort and the same support will be provided. This means the pressure support is not varying at all and the patient is getting the same support. This becomes a problem when the disease is dynamic and patients are trying to come off the ventilator. If the support is not proportional to their effort, then there can be asynchrony and the ventilator and the machine, the patient and the machine can start fighting each other. Because of this issue, researchers came up with a mode called proportional assist. That is, this mode basically provides pressure support in proportion to the patient's effort at that particular point in time. How does it do that? It actually measures, there's a mode called PAV and PAV plus. I'll only talk about PAV plus. PAV plus is what most modern ventilators have. This mode continuously measures the resistance, the compliance, the flow, the volume, the pressure, the dynamics, and keeps titrating the support that it provides based on the patient's instantaneous effort. Because of this, there is an auto feedback. There is a smoother interaction between the machine and the patient. There is better synchrony. So this is the biggest advantage of proportional assist ventilation. This therefore results in a better coupling of the neural and the machine drive. About 2 or 3 years back, I led a systematic review looking at what is the overall data of proportional assist across all critically ill patients and acute respiratory failure etiologies. There was very limited data, very small trials. We did not focus on specific outcomes such as weaning, but when we looked at it, there was a dearth of evidence. The only thing we consistently found was there was much better synchrony with PAV as compared to any other mode, but we couldn't show that it translated into better clinical outcomes. More recently, in 2020, there's been another meta-analysis looking at PAV versus pressure support for weaning. And what this meta-analysis found, they had 7 trials, very impressive effect on the weaning. So if you look at the weaning success, which means patients coming off the ventilator and staying off, PAV had a relative risk of 1.16. That means a 16% higher chance that somebody would get weaned with PAV as compared to pressure support. And a lot of these trials did have COPD patients. Whether the data is directly extrapolatable, I can't say, but clearly the newer mode seems to have some benefit in terms of weaning, but we do need a larger trial to confirm these preliminary findings. The next new mode, which is related to PAV, is called NAVA, or Neurally Adjusted Ventilatory Assist. NAVA is one step advanced or more advanced than PAV. It also provides proportional support, but here what we do is we put an NG tube, but this NG tube is a special NG tube, feeding tube, which also acts as a catheter. It measures the diaphragmatic electrical activity. Therefore, whenever a patient takes a breath, the neural drive acts and the patient takes a breath, it measures the diaphragmatic electrical activity. Therefore, it knows how much inspiratory pressure or how much drive is there, and then it provides proportional support. So it takes it one level further. It's invasive because you need a catheter, but it actually measures the electrical activity and therefore then provides support that the patient needs based on their drive. So again, as expected, it improves synchrony much to a larger extent than even PAV could potentially do. Is there any data to support NAV? There's a very recently published randomized control trial in all acute respiratory failure. They had 310 patients in this trial, all adults with ARF. They compared NAVA to conventional lung protective ventilation, and the primary outcome was ventilator-free days up to day 28 after randomization. You look at the baseline characteristics similar. What I wanted you to note is there are about 33 COPD patients in this trial. So there is some representation, but they're about 10% of the, less than 10% of the total, about 10% of the total cohort. But otherwise, both the groups are matched with respect to all their baseline characteristics. What does the trial find? In their main outcome, ventilator-free days, a significant benefit for NAVA. It seems like there were 4 more ventilator-free days in NAVA as compared to the control group, and this was also statistically significant. No change in other secondary outcomes, but on the primary endpoint, NAVA seemed to be beneficial. And this is exciting data for us in the critical care world, and I think there will be more follow-up studies looking or confirming this effect. This is the survival data, which was not different, but as I mentioned, the primary outcome was different. This is a study from AIMS, Delhi, comparing NIV NAVA to NIV pressure support in patients with COPD specifically. It was called the NAVA NICE trial. And in this trial, they included 40 subjects with COPD and acute hypercapnic respiratory failure, and they randomized them to NIV NAVA or NIV PSP. And what they found was the asynchrony events were significantly less with NIV NAVA as compared to pressure support, but there was no improvement in any of the other outcomes. Again, some data confirming the benefit of NAVA on synchrony. Another study that confirms the same data on synchrony. So that's about the newer modes. I'll just go to my summary slide and wrap up. So with COPD weaning, just to say that we need to consider specific factors such as frailty and pre-admission multimorbidity. Our spontaneous breathing trial, even in COPD, remains the best predictor of weaning success. We need to consider all the modifiable and reversible reasons for weaning failure. No mode is superior, but we are seeing some promising alternatives such as PAV and NAVA. NIV is very important, very critical, and there is a huge role for NIV in COPD. The role of ECOR is evolving, very exciting area. We need to wait for the results of the trials. No role for acetazolamide. And the basic principles of weaning, we need to adhere to and stick to, and that will perhaps result in the most success. Thank you so much for patient listening, and this is again my email, my Twitter handle, and you can write to me. Thank you. I'm going to stop sharing my screen.
Yes, thank you, Dr. Bharat Kumar. It was such an in-depth presentation on the entire process of weaning, starting from the trends to the clinical observation criteria, guidelines, and also the newer methods. It was really insightful. And so let's go on to the question and answer session. So can we go on to the question and answer session, sir?
Yeah.
Yeah. So
before that, are there any critical comments or questions from somebody? Any points, Shantakumar or anyone? Before you throw it open, no? You have any comments to make on presentation? Shantakumar, your experience? Harish, you also can share your experience.
Yes, so this, I think PAV plus would be probably coming out in a big way because it measures the real-time data in with each breath. I think that will be the thing to watch for, and also it's a commonly asked question for PGs in pulmonary critical care.
Yeah.
So, PAV plus and NAVA. So I think PG should take note of this, and also the criteria for weaning. It's very important, like the crop index and also the spontaneous breathing trials and RSBIs. All this, I think the PG should know it. And also more on this, it's a clinical assessment and judgment also along with it. I think that is also most important along with all this. So, and also the commonly missed is the electrolyte imbalance in the ICU. Usually the hypomagnesemia, which usually we don't watch for, or it's commonly overlooked. So I think that also plays an important role. And also, as rightly pointed out, overcorrecting the type 2 respiratory failure, overcorrecting CO2, it really has an impact what we have seen in the weaning process itself. So it was all well elucidated by Dr. Bharat. I think I don't have anything more to add on because it's almost entirely covered. The entire spectrum is covered.
Yeah. So we'll go on to the
Dr.
questions.
Ajay, I just have, I missed the initial part of the presentation. Sorry for that. But I just want to know what is where do you call the surgeon in case of COPD, either be it stable or in the ICU? I mean, you would have seen pneumothorax, I think, is a very major deterrent factor in trying to wean the patient off the ventilator. I mean, what is your experience regarding that and the air leaks? What do you think about that part? Both for, I've asked, yeah, Bharat, can you Dr. Bharat, can you unmute yourself?
Yeah, I
Yeah.
was sorry, I was on. I think I just unmuted. Um, uh, Not so much in the weaning process, I think, but definitely like Dr. Ajay, you pointed out, only when we have complications,
Okay.
when only when we have challenges, and obviously if there is a huge pneumothorax or if it results in a BPF or whatever, we definitely cannot manage without the support of the thoracic surgeon and the surgical team. But in a routine weaning, I don't think that there is any, obviously there's any role in the event of complications for sure. Yeah.
Okay.
And also, Dr. Shantakumar, do you like to answer this
No,
question
I think Dr.
on
Santakumar is
maintaining?
not able to unmute himself. I'm just trying to unmute. Yeah, sir, can you unmute yourself now?
Yeah. Am I audible?
Yes, you're audible, Dr. Shantakumar. Yes.
Yeah, I just missed the initial. What is the question, Dr. Harish?
The role of cardiothoracic surgeon in COPD.
Both stable COPD, I think we have play a slightly more role when there's a bullous
Yes.
lung disease and all that. But
Yeah.
what about?
Yes, actually, I put two or three slides in the last part of my presentation as a role of a surgeon in COPD when the disease component is more of a bullous lung disease with this predominant emphysema, heterogeneous emphysema. Then the question of volume reduction or LVRS comes in, and of course the end stage COPD, no other option is available. The transplantation is the final option. And during weaning and patients with exacerbations, one of the common association or common risk factor for exacerbations is a pneumothorax, as you rightly said. And some of the patients we see with pneumothorax and COPD, it is very difficult to wean them from even ICD also, especially if there is a bulla which is ruptured into and which is leaking into, patient is especially ventilated, then that patient becomes very disastrous for weaning as well as the intensivist as well as the pulmonologist, and we are not able to ventilate the patient and we are not able to wean the patient off. In that case, then probably a surgeon's role is critical, where we need to take the help from cardiothoracic surgeon and
Do a bullectomy or something.
no, bullectomy is a radical thing. So the initial part, some bronchofistula closure sort of thing, we can assess the minimally invasive surgeries. If that fails, then probably a bullectomy would help.
Yes.
Bharat, I have received one question to you, Bharat. When you try to intubate these patients of COPD, do you prefer a sedation or a paralysis, or do you maintain the patients on paralytics? Because this has the relation. The question that they have sent me as an SMS is, you had mentioned about the ventilator-induced diaphragm failure. Does that happen also with tracheostomy-related diaphragm failure and prolonged respiratory paralysis associated diaphragm? That's a very big question they have asked. I just briefed it. Someone from Chandigarh.
Thanks, sir. Thank you. Yes. So to intubate the patient, we do paralyze. That is, we have so consistently the data is that by not using paralytics, you actually make your easy intubations into difficult intubations and you complicate things. There are some proponents who will say with just a sedation you should tube, but our unit and generally the global practices at the time of intubation we do paralyze. Post intubation, we do not routinely run any paralytic infusions in our ICU. We try to keep them on a sedative, but we also lighten the sedation or even stop the sedation every day to assess whether they are ready for weaning, unless the disease condition is so bad that we are not able to back off on the sedation. In terms of diaphragmatic dysfunction, yes, if we keep them paralyzed and keep them on a control mode throughout and don't allow them to breathe, definitely they would have diaphragmatic dysfunction. But like I said, the current practice in any reasonable quality ICU would not be to run paralytic infusions. It would be, there is only one instance where we would run it, which is really early ARDS when we are not able to, oxygenate the patient. And there a trial of 48 hours of paralysis may be considered. But other than that, we don't paralyze our patients after the initial intubation itself. They're all on a combination of sedatives. There'll be an opioid such as fentanyl, along with either propofol or midazolam. And every day we will try to wean off the sedation, wake them up, and our attempt will be to do daily SBTs if possible, and as soon as possible extubate. Prolonged ventilatory, not just prolonged paralysis, prolonged use of control modes also will cause diaphragmatic dysfunction. We need to allow patients to breathe spontaneously and use their diaphragm. So we try and transition to a spontaneous mode as soon as is possible, and we allow the diaphragm to work. So definitely, this is now being called the diaphragm protective ventilation. A new concept is emerging. Like lung protective ventilation, there's something called diaphragm protective ventilation coming up. So we are definitely focused on that.
To add on to this, the diaphragm protective ventilator strategy, they give periods of rest in between. So I think that is again very important, newer methodology catching up here. And also next question is for Dr. Shantakumar. How do you define the disease worsening in a COPD? I think you answered this in your slide itself.
Yeah. So disease worsening means it's a progressive worsening in terms of the gold defined status, or it's an acute exacerbation. We need to identify that. Basically, acute exacerbation is clearly defined as that disease worsening from daily day-to-day activities. So in terms of symptoms, increase in dyspnea, increase in the amount and purulence of the sputum, along with other signs and symptoms of prodromal symptoms, infections, and typically patient comes with you with hypoxia, hypercapnia, lands in admission or ICU. So this is classical exacerbation. It's in acute worsening. In terms of a progressive worsening, if you follow them up over the period, then probably patients FEV1 fall may be significantly high in terms of disease worsening, and other parameters, 6-minute walk distance. So all these things has to be periodically monitored. And a good index for good criteria for assessing these patients is the board index, as we all know that. So we can assess the board index and gold status and grading of the dyspnea can tell that disease is worsening or not. So we need to
one question, Harish. There is one question for Shantakumar on YouTube.
Yes.
Is there a role for leukotriene antagonist, anti-pulmonary hypertension drugs in COPD, stable COPD? And how often should one think of? If there is a pulmonary artery hypertension in echocardiogram, do you think of drugs to control it with?
No, sir. I think.
Or you try to control hypoxia only? Yeah.
Yes, sir. I think the hypoxia-induced pulmonary vasoconstriction is the mechanism of action of pulmonary hypertension in COPD patients. I think sometimes it can even worsen by changing the ventilation perfusion mismatch. Also occurs in giving pulmonary vasodilators. I would not do it, sir.
Most of the studies,
yes
and no, I would agree with Dr. Harish. So no study has shown a benefit of pulmonary vasodilators in secondary pulmonary arterial hypertension like in COPD. And in fact, sometimes they may worsen the VQ mismatch, and hypoxia can be worsened by this. Unless otherwise, there is a clear indication like a primary component of pulmonary arterial hypertension is coexisting with this, which is very difficult to find out. And probably I would be very hesitant to give pulmonary vasodilators in these type of patients. Rather, I would I would be interested in treating the COPD more intensely than targeting the pulmonary pulmonary arterial hypertension.
Even if you optimize his oxygen levels with a domiciliary oxygen treatment and also he's otherwise stable, in such situations, you think the pulmonary hypertension need not be treated?
Actually, in that case, definitely I would be interested in ruling out a pulmonary thromboembolism, chronic pulmonary thromboembolism, because if there is a pulmonary thromboembolism, it is going to definitely worsen because it is a pre-capillary obstruction. So it is going to worsen the hypoxia in terms of may cause sudden pulmonary edema also. So I would definitely rule out a chronic thrombopulmonary embolism. If it is ruled out, and if I feel that the pulmonary arterial pressure is disproportionately high than the existing disease, which is expected for the COPD level of COPD, then probably there may be a coexisting primary component in that particular patient, especially females. Then probably I would give a vasodilator assessment like nitric oxide and all, and I should assess before giving a pulmonary vasodilator, either nitric oxide.
Yeah, so that's a very important point in stable COPD management, Shantakumar. If you have a patient whom you think you are optimized, but still the pulmonary artery hypertension persists, you need to investigate for pulmonary embolism. Can you take the question straight back to Bharat there? Bharat, how would you manage if you have a patient whom you think you are optimized and your pulmonary hypertension is pretty high in such patients? You tend to think of pulmonary angiogram or CT pulmonary angio or something like that, or what's your take on that?
Absolutely, sir. We definitely would do a CTPA, and I think there's lots of data to suggest that there'll be incidental, segmental, subsegmental, and even major PEs. So that would definitely be our approach. I think there's data even from India. There's, if I remember, a study from PGA which looked at this as well. So we would push for a CTPA. I also agree that I'm not sure that there's any role for adding on drugs to treat the pulmonary hypertension without if it's a secondary pulmonary hypertension. We have not found any major benefit in that strategy.
Yeah.
There are 2 questions in the chat actually. There are 2 questions. Yeah, sorry.
Yeah, go on, Ajay.
No, I think there's one question I think has been directed to Dr. Shantakumar. Sir, could you please explain how to measure collateral ventilation and how to decide when LVRS is needed?
Oh, Manisha has asked. Yeah.
Yeah, there are special software assessment and special tomographic assessments for collateral ventilation, which every institution may not have it. So that is one of the assessments. And the another thing is usually we introduce a balloon into that particular segment and occlude the particular segment, and we have to see the complete collapse of that particular segment after occluding it. If the segment is not completely occluding, then probably that segment is getting a collateral ventilation from some other segment or nearby segment. That may indirectly tell you that this is a collateral ventilation. That is the usual method before occluding that particular segment by a valve or by coiling that is being followed. And there are some volumetric CT assessments also to find out the collateral ventilation.
Yes. And then other question to Dr. Shantakumar, and for the benefit of the PGs also, and on an infective exacerbation of COPD on a background of type 2 respiratory failure. So what is the role of steroids? This is very commonly faced clinical scenario.
Very commonly faced and a very difficult scenario also. My approach would be what is causing the acute exacerbation. I would definitely interested to find out whether the pneumonia is causing the acute exacerbation and what type of pneumonia. For example, if it is a H1N1 associated pneumonia causing the exacerbation, then probably steroid may be detrimental as proven by some of these studies. And for example, if it is the ongoing pandemic, if the COPD patient comes with the COVID pneumonia, then probably steroid will be beneficial in that case. And if it is a bacterial pneumonia, then the scenario is different. So clearly, all the studies which have been done on acute exacerbations without pneumonia have shown definitely a benefit of beyond doubt proven it is steroids are beneficial. In terms of early weaning from the ventilator, in terms of reducing the hospital stay, in terms of preventing further exacerbations. But in pneumonia, there are for and against studies also for steroids. My approach would be to assess the patient with the antibiotics and other medications for initial 1 or 2 days, how the patient is doing. If the patient is not improving or if the patient is not coming out of the ventilator, weaning difficulty, and the COPD component is predominantly there, then probably I would try with steroids.
Yes, I also agree with that, Dr. Shantakumar. There will be a more rational take on this infective exacerbation with type 2 respiratory failure.
Harish, can you take that question back again to Bharat? In ICU setting, what does he do in acute exacerbations of COPD? Yes. There is always an ongoing debate between the pulmonologist and the ICU guys. Yeah. Let me get Bharat's views on that.
Sir, interestingly, I am okay if the pulmonologist feels that a steroid should be given. The reason is if you're going to give a 40 milligrams of methylpred dose alone, that to me is the dose that we would give in our sepsis and septic shock patients. So it's not a dose that, I'm convinced will worsen the recovery or, make problems for me from a bacterial infection standpoint. So for most of our COPD patients in discussion with the pulmonologist, if they say, I want to give 40 milligrams for 5 days, or for 7 days or whatever, I'm usually comfortable with that. If the dose is much higher, then I'm a bit queasy. If somebody wants to give, 80 BD or something, or 125 TDS, then I think I would be a bit worried. But if you're giving a lower dose, I would be comfortable.
Is it the infection that bothers you, or is the steroid myopathy that bothers you?
At the 40 milligram dose, I'm not worried about either. If the benefit on COPD, for the exacerbation itself is higher, but at the higher dose, I'm worried about infection as well as steroid myopathy.
Right. Okay.
Another thing is in COPD exacerbations, short course of steroid 1 milligram per kilogram prednisolone equivalent is equally beneficial or more beneficial than the long-term steroid. It's clear, it's clearly proven that a 3 to 5 day course is more than enough for a COPD exacerbation. And one of the other problem in high dose steroids is hyperglycemia for ICU patients.
Yeah, right.
Yes, and one more commonly faced clinical scenario which we see is a chronic smoker, elderly person who's having a normal PFT but comes with breathlessness, dyspnea on exertion, chronic cough. Do you still treat him as COPD or wait for evidence until the spirometry changes and then start him on inhalers?
Initially, the patient is not fitting into COPD as far as the spirometry criteria is concerned. I would symptomatically treat the patient with anti-inflammatory things and all. The patient is not responding, or if the post-infective bronchiolitis component or airway inflammatory component is more, then probably I would try and use a short course of inhaled steroids and see how the patient is responding.
Or would you like to work on further like DLCO and other measurements, diffusion measurements in this case, who's having a normal PFT, but still he's a chronic smoker?
Yes, definitely. Early COPD may be having a less diffusion capacity. Early emphysema, which is not involving the airway, may show some DLCO thing. But as far as the COPD definition criteria is concerned, we follow only the airway spirometry criteria. So
yes.
the difficulty in diagnosing this COPD.
Yes.
Yeah, we don't. It's sometimes difficult to diagnose. I agree with you, Shantakumar. Diagnose COPD based on diffusion defects, actually, because there could be a component of ILD or something.
Yes.
We define criteria based only on the airway measurements, FU and FEC ratios. I think that's a better way of doing it than doing a DLCO. Unless you have an alternative diagnosis as an option, I don't think we should think of diagnosing a COPD with a diffusion.
Yes.
That's what my personal take on that. Right. There are no other questions?
There's one more
Any other
question to Dr. Bharat. NIV has revolutionized the management of AE-COPD. What is the proportion of mechanically ventilated COPD patients in your ICU? When will you suggest a home NIV for a COPD patient?
Great question. Very few patients in our ICU with their initial exacerbations end up in the ventilator. I would say maybe 1 in 10. But the patients who have recurrent exacerbations who are coming in, the frequent flyers, there the proportion might be 30 or 40%. Definitely in the people who are in this was the first or second episode or whatever, we mostly get away with NIV. We rarely are forced to ventilate those patients. On home COPD, I would defer to Dr. Shantakumar. I think it's better that one of the pulmonologists take that question. When would you recommend home NIV for a COPD patient?
Yes, so the stable COPD patients, yes, the guideline says that there are some criteria for starting on long-term oxygen therapy as well as NIV. So as far as NIV is concerned, the patient is having a chronic refractory hypercapnia, which is uncorrected, then that patient may be benefited by home NIV. And those patients who are coming out of an exacerbation, coming out of a ventilator, who might require some sort of a stabilization for 2 to 3 weeks or a few months on NIV, then probably that patient would go with NIV to home in our hospital. And another situation is COPD OSA, coexistence. OSA is a common comorbid condition where obesity, hyperventilation, or obstetric sleep apnea is a comorbid, then probably those patients will benefit the home NIVs. So
the preference is for auto CPAP or CPAP or BiPAP, Shantakumar?
We used to give BiPAP, sir.
BiPAP.
At least in the initial part of the management.
I just wanted to add a point on the NIV except for exacerbation. The only thing I think for a pulmonary PGs to know is to recognize NIV failure. NIV is a great device and it's definitely revolutionized, and we end up not intubating several of those patients. But it's also equally important to know when NIV is failing. And I think that's a key skill to have, whether it is on the ward, whether you're trying, or whether you're trying in the ICU. So if you're having obvious hemodynamic instability, neurological deterioration, if this, you've given a trial of 4 hours, the pH is going under 7.15, if the consciousness level is deteriorating, if the risk of aspiration is high. So all of those are indications to take over and ventilate. We would definitely give a trial of 4 hours, but you need to be at the bedside, watch and make sure that there is improvement, along with, of course, institution of bronchodilators and so on. But recognizing when NIV is not working, I think is a key skill to pick up.
I think that needs to be educated to the patient's family as well when we are sending them home with NIV. It's a very, very, very important point that you have touched upon, Bharat. Yeah. Any other questions? If there are nothing else, shall we close the session?
Yes, sir.
Harish?
Yes, sir. There are no other questions here, sir.
Yeah.
If there are no other questions, we can close it.
Yeah. In that case, I thank Dr. Harish for his excellent way of moderating the COPD session. Though he is very young, he did it like statesmanship. Generally, the moderator role is taken someone like me, who doesn't talk much, and then Harish did an excellent job on that. And I also thank Bharat for having accepted our invitation and share his thoughts on the ventilatory aspects and especially the weaning strategies in COPD. And I also thank Dr. Shantakumar for having accepted. It was a very good talk, and it was very well accepted by many people. The number of questions, I think still there are some more questions. Anything Ajay, you want to say? There are still some more questions that are cropping up. That itself means that there are, you provoked the people enough to ask them a lot of questions. It was really very good. It's a great show, right? And I also thank the Sun Radiant for their generous thing. They have been doing this for the past 7-8 months. I thank them for all. I thank you all, and most importantly, the participants who came and participated in large numbers today. I think COPD generally does not evoke much interest. I think today's topic evoked a lot of interest. The stable COPD and the weaning strategies has evoked so much of interest that we had about more than 80 participants in YouTube and the Zoom together. Thank you all. I close the session. Thank you very much.
Thank you, sir. Thank you all.
Thank you all.
Yeah.
Thank you.
Bye, Bharat. Bye, Shantakumar. Bye-bye.
Bye. Thank you, sir.
Bye-bye.